Welcome everyone to our mentoring session, and we are appreciative to have your attendance and time. I want to again, as I did a little bit earlier, to encourage you to make progress regularly in the self-study materials. This will really complement your progress through the mentoring sessions, but we have so little time in the mentoring sessions that you really do need to do the self-study material. And I know that with busy lives, that's a challenge, but we've tried to break down each unit into smaller pieces so that you can do a little bit each day or every couple of days, and thus get through that material over the course of our year. So, Wandwosen, do you want to take the floor and share your slides? Is he, if you're having trouble sharing, you could also email the slides to Felicity to share, or it looks like he's having a problem. Can you unmute and tell us what the problem is, Wandwosen?
I have already shared the case with PPTX 2 days ago. It's available in session 4. It's labeled as study materials, I think, something like that.
I am looking at those now. Case one looks like a case one is a weird file, and so it's not opening, but case two is. I could check case two. Yeah, it looks like there was an error with the upload on case one. Um, but let's go ahead and pull up case two. Is this okay, one Wilson?
Yes, we can see the screen fine.
Take us away.
Okay, do you want to go to the next slide? So we've got an intramural mass. It's a little bit heterogeneous. We've got some yellowish coloration to it and generally smooth margins, sharply demarcated from the surrounding myometrium. But maybe a little bit difficult to assess all the margins, a little bit irregular in a couple of areas. Okay, next slide. Yes, there. Yeah. Is this the ovary? Yeah, the right ovarian tumor. Okay. Okay, so different appearance than the myometrium. Cystic and very hard, almost calcified areas. Let's go to the next slide. Yeah, so very acellular hyalinized fibrotic tissue. No nuclear detail there. And next slide. Ah, there's something. So we can see at low magnification a little cartilage in the upper left. We see the cyst lined by a stratified epithelium, maybe a hair follicle on the right. And then at the bottom, we see a follicle forming structure with pink luminal contents, certainly very reminiscent of thyroid type tissue. So it looks like a teratoma. Next case, or next slide, I mean.
Next is also more or less the same. We see the stratified columnar epithelium at the upper part and some fibrous tissue. We can go through next.
Yeah, and there may even be a little hair structure, or I guess maybe some small follicles there. Okay.
Sure. Next. Next is a closer view of the follicular structure filled with color. As you can see, the follicles are variably sized. Some are empty, some are filled with colored light material. Next. And this is again another area where you see, as you know, a cartilage, mature looking cartilage.
Very good. Yeah.
Next. So the right ovarian mass, there was no immature component. So tissues, adult mature tissues were seen derived from speech layers, mesoderm, endoderm, ectoderm. So the diagnosis was mature cystic teratoma. Actually, the interesting case, finding in this case is from the uterine mass, as you see it, which thinned out the myometrium, reaching to 0.5 centimeter serous aspect of fundal part of the uterus. So this is a low power view, which is very, very difficult to see. There are these bundles of spindle cells. Can you go to next slide? Here also, this bundles of spindle cells is very difficult to appreciate their nuclear appearance, but they look like they do have some form of cigar shape and they run in fascicles. Next. Closer view is the same thing. As you can see, the cells a bit probably variable size and shape. For me, it looks probably moderately atypical. I'm not sure the one we see in the center, whether it is apoptotic bodies or mitosis. It's very difficult to confirm whether it's mitosis or not. Next. Here is more or less the same thing with spindle cells, transfers we cut with some moderate, I would say, at cytological TPL. Next. And this is better, as you can see, these are spindle cells that are in fascicles. There is some cytological TPR, probably that TPR, not that much market, I would say probably moderate. So the cells, they look like spindle cell. So the diagnosis which was entertained is spindle cell tumor, so the myometrium, where you have many differential diagnoses. So next. So the block was sent to a private lab. In the private lab, they performed immunohistochemistry from the uterine mass. It's a bit pale stained, but what they say is there is a positive smooth muscle actin here and there, not in diffuse fashion, but focally here and there, it was positive. Next. And they also performed P16, which, as you can see, is also not that much remarkably, probably or refusely positive, but the interpretation from that private lab is, as they say, it is positive as well. Next. The ER, estrogen receptor, they say it is negative, as you can see also here, I don't see any positivity. Next. They also do KS7 immuno, and they say roughly it is 50% positive. Next. So finally, the private lab performing this batteries of probably immunohistochemistry, they say that the uterine mass, the immunohistochemistry histology is supporting of neomasarcoma. Because this was not my case, I communicated the resident who performed the grossing as well as sectioning and microscopic interpretation. They informed me that there were areas of tumor necrosis as well as brisk mitosis. But the unfortunate thing is in the sign-out report, the number of mitosis were not reported and no mention about the tumor necrosis. One of the drawbacks I see in synoptic reporting is it doesn't allow you to give the number of mitosis you see or whatever powerful you saw or whatever area or millimeter area you saw. And also the tumor necrosis was not also mentioned, but actually they say that they saw tumor necrosis and brisk mitosis with moderate atypia. As you know, it's 2 of the 3, so the atypia there, tumor necrosis was seen, as well as the mitosis was brisk, and that's why even on HND they diagnosed conventional or spindle cell neomasarcoma. That's how this case was reported. The adnexal mass or the ovarian mass was straightforward. It was reported as what we call not cystic teratoma. Next. So this is the synoptic report. As you can see, there is no probably area which you can suggest. I think we have to improve on that line. There must be a summary of histological finding prior to synoptic report, and the synoptic report will follow, and so that whoever is probably trying to review the case may not be confused. I was so confused to suggest sarcoma because I failed to appreciate the mitosis in the at least examined slide, and but actually they say that they saw that and the mitosis was reported as brisk. So this is the case for probably your expert opinion. I found it very interesting.
Yes, I think this is very interesting sort of case, and there are several questions that I think come up with this case that I think continue to perplex us and annoy us at times. So let's first talk about the ovary, mature cystic teratoma. This is obviously a quite common disorder, and it's common in a wide age range, because probably, as you indicate in this situation, that tumor has been around for quite a while, probably maybe 10, 20 years that it's probably been there. And so that leads to more hyalinization, more calcification, and so forth. But also, as we have as we have this tumor in advancing ages, we do run an increasing risk of a somatic type of malignancy involving the teratoma. And the secondary tumors that occur in a teratoma are, as one would expect, most commonly squamous cancers. That's the dominant epithelial type that's present, and if they get that additional hit or whatever, that they may develop a squamous carcinoma. But there are a variety of other tumors that can also arise in the ovary from a teratoma. And one of the more confusing ones sometimes is a mucinous tumor, which can mimic the usual type of ovarian mucinous neoplasm, and also can appear as a metastatic type tumor, as a colonic enteric type of carcinoma. And so recognizing that tumor arising in a teratoma is a possibility always comes into the differential when you're dealing with an older woman with a mucinous tumor, mucinous carcinoma of the ovary. There are additional tumor types of varying types, stromal derived, and so forth, that can also come into play. But those are extremely uncommon, and usually will have a different morphology, and you'll have some clue that there's a teratoma there as well. So I think that's an interesting part of this. Now, the other question maybe that would be considered is uh, thyroid tissue and the development of a thyroid neoplasm, thyroid-derived neoplasm. That would also be, I suppose, a consideration here. We see fairly frequently, we see a papillary carcinoma coming out of a struma ovarii, or we see other expanding thyroid type neoplasms in this setting. So it certainly is a good idea if they've been identified, and you can identify what they likely are very often because of the heterogeneous nature of them on imaging studies. It's still a good idea for them to be removed where possible, so that you don't get those later effects of complicating a mature teratoma. So smooth muscle tumors in general in the uterine corpus, again, very common, and they do present this challenge of classification at times. I thought when you showed me the low power image of this case that we were going to be dealing with maybe a variant of a leiomyoma, because it didn't appear very pleomorphic. The cellularity was kind of on the moderate side of things. And the morphology looked fairly typical. At low magnification, I didn't see any specific nuclear pleomorphism that jumped out at me. And so I realized that we probably were not dealing with one of the considerations, which is the leiomyoma with bizarre nuclei. or with the fumarate hydratase deficient leiomyoma, which can also have atypical and bizarre nuclei. One of the higher magnification views of the tissues did show a cytoplasmic eosinophilic inclusion type body that is sometimes a clue to think about fumarate hydratase deficient tumors. And of course, that diagnosis is one to be considered because if you identify that situation, those patients also may be associated, may have a genetic defect that is associated with some renal cell carcinomas as well. So that's a good diagnosis not to miss when you're looking at a smooth muscle tumor that's usually not mitotically active, uh, but has pleomorphic nuclei and atypia, and perhaps those eosinophilic inclusions. Now, unfortunately, the demonstration of that diagnosis does require access to a fumarate hydratase immunohistochemical stain. But if you don't have that and you have the characteristic morphology with the eosinophilic inclusions, you can certainly make the suggestion that that can't be excluded and is a possibility, and that they should consider surveillance for associated renal neoplasia. I think that's acceptable care in a situation where your resources don't allow you to make that definitive diagnosis or exclusion. Probably the same sort of thing should be mentioned in cases where you see smooth muscle tumors with bizarre nuclei, because in the longer term study of this issue, ultimately a fair proportion of those cases that were initially diagnosed as, leiomyoma with bizarre nuclei have ended up being reclassified as fumarate hydratase deficient tumors. So that is a distinction that a very experienced eye might be able to suggest. But I think anytime you have the smooth muscle tumor with bizarre nuclei, you should include in your differential the possibility that this is a fumarate hydratase deficient patient, and raise the issue of screening for renal tumors. Okay, so where do we go with leiomyosarcoma? Of course, our big three criteria are mitotic activity, necrosis, and cellularity. So the mitotic activity in this case has been supported by the Ki67 stain with a high labeling index. I still think that a mitotic count would be useful for people to know those cutoffs. And of course, the cutoffs are different based on the morphology. You've characterized this correctly, I think, as a spindle cell or conventional type tumor. But the cutoffs drop down to much lower levels when you're dealing with a myxoid tumor, or whether you're dealing with a epithelioid leiomyosarcoma. So those required only many fewer mitotic figures per high power per given area to reach the classification of leiomyosarcoma. So that distinction is important, and I will tell you I don't retain in my brain the actual cutoff numbers, so I can't spout those without looking it up, but I know where to look. And when I start seeing mitotic activities, I go and look, and then I make my count. Um, So, in terms of how do we make a mitotic count, um, there are a couple of ways of doing it. And I'll just give you, my method is probably a little bit of a lazy man's approach. I will do several areas where I will count, up to 50 high power fields. And in doing that, as I tabulate those numbers, if I very quickly get to exceed the threshold, uh, then I probably will stop there and conclude that the mitotic activity is too high. Um, when you're dealing with just mitotic figures and no atypia, no necrosis, that that situation, I'm much more careful to make sure that I've counted the correct area and that I have the as accurate a number from several different areas as possible. In general, we don't do an average. We do the highest count that we obtain by counting in a particular area. So if I get, 25 mitotic figures per, 50 high power fields in one area, and I get 10 mitotic figures per 50 high power fields in another area, and I get 12 mitotic figures per 10 for 50 high power fields in another area, I don't average those numbers. I use the highest count because we know that these tumors can be heterogeneous in terms of the distribution of growth centers. And so we will want to use the so-called hot spots for mitotic activity as the threshold. And that's important. I think sometimes trainees they just count one area and they think they're done, but you do need to sample multiple areas to make sure that you are not under reporting this, because that's the risk. You don't want this patient to show up in 5 years with lung mass, and then have them come back to your slides and say, "Oh, you called it a mitotically active leiomyoma, but really there's, too many mitoses for that classification, and it should have been called a leiomyosarcoma, or at least a smooth muscle tumor of uncertain malignant potential." So that always haunts us, that we know that situation occurs where patients show up many years after a hysterectomy and they have a lung mass and it's a smooth muscle tumor, and we go, "Oh no, did we miss it? Did we make the wrong diagnosis?" Um, and it doesn't take very many of those kinds of experiences to teach you to be very diligent in your assessment. The other area, which I think presents some difficulty in terms of classification, is identification and classification of necrosis in these tumors. And as you know, there are a variety of appearances for necrosis. Some are benign and some are much more frequently associated with malignancy or neoplasia. So the easiest ones are the ones where you have a high cellular area and right next to it you have ghosts of necrotic tissue. That is tumor necrosis. And that is one of the criteria for malignancy. The other very easy one is where you have a very hyalinized fibrotic area that becomes acellular. That is hyaline necrosis, and that's benign. So those are the two easy ones. The more difficult area, or the more difficult type of necrosis, is the type that's sort of intermediate between there. And it usually is benign. It's maybe a little bit harder to describe, but you have an area of cellular tumor, and then you have a margin of what may appear to be uh, granulation type tissue, a few small vessels, a little bit of hemorrhage. And then adjacent to that, you have a more acellular necrotic area. So this type of necrosis, that description is frequently is benign, most frequently perhaps, but it can occasionally, I think, be seen in leiomyosarcoma. So when I see that type of necrotic change, I am very careful to do my mitotic count. However, I do not count mitotic activity in that granulation zone and immediately adjacent to it, because we know that there are local factors that are producing a stimulus to mitotic activity. So that's the one situation where I would not use my higher count in that particular area of the tumor as an indicator of malignancy, because that's probably a very likely response to the granulation tissue ischemic stimulus that is going on, or the healing stimulus in that particular area. So those are my thoughts. I will say one other thing that can occasionally be useful as a criteria, and that is an infiltrative margin. So in this case, your immunohistochemical stain, at least one of them, showed a variable packeting or nodularity that appeared to maybe be associated with an infiltration of the myometrium. So that can be useful as well as a criterion. And that specifically is a useful criterion in the lower mitotic activity types of tumors, such as a myxoid leiomyosarcoma or an epithelioid leiomyosarcoma. So that's a soft criterion. It's not one of the big three, but it's one that should still be evaluated where you can. So what is the role for immunohistochemistry in these? Well, we don't have a clear-cut indicator that says this is benign, this is malignant. We have supporting features. So the Ki-67 that is very high can be useful. And so in this case, if it really was 50% of cells were positive with Ki-67, that would be a pretty strong supporter for malignancy. But if you're looking at something that's maybe 10%, that probably isn't enough to make the diagnosis of malignancy. Now, some institutes will use the P16 and P53 markers as further evidence of malignancy. And certainly if you have definite abnormalities in that setting, and you have the other features, then I think you can feel more confident. More typically, though, we have maybe a cellular leiomyoma, and we have P16 and or P53 that are abnormal. And that's not enough to make the diagnosis of malignancy. It is enough, in my mind, to raise a bit of concern about possible malignancy. And so in that circumstance, I might make a diagnosis of cellular leiomyoma with atypical molecular immunohistochemical features, and suggest that that patient get a period of follow-up to exclude the possibility of spread or recurrence or other type of behavior. Usually, if those lesions are fairly small or they're resected, of course, that's going to be just a couple of visits and a clean bill of health and so forth. But if that lesion was larger, maybe a bulky leiomyoma with those features, and it's a dominant mass, well, then the possibility of them having a uncertain malignant potential or more aggressive tumor type goes up. I did pull up the path outlines page for smooth muscle tumors of uncertain malignant potential. And this is useful to review if you're in that borderline category, because the features that you describe will play a pretty significant role in terms of the likelihood or risk of progression. And I just refer here to the um, pathology outlines page on smooth muscle tumors of uncertain malignancy. And note that there are some features that have a significantly higher risk of recurrence, such as epithelioid tumors or myxoid tumors of uncertain malignant potential. Those may have 20-30% risk of recurrence or aggressive behavior. Um, And again, they emphasize that the immunohistochemical markers in these situations have no specific prognostics value, as do atypical mitotic figures. So those things may raise our internal sense of concern about something, but they don't necessarily imply that it's a particular category or malignancy. So any questions or additional comments on these smooth muscle tumors and the diagnosis of leiomyosarcoma?
Yeah, one question I have is this leiomyosarcoma of the uterus nowadays, the grading is not favored. They say that most of them are high grade, so I think grading is not usually reported. Is that
Right.
true?
That's true. We don't grade these tumors.
Okay. The other question I have is actually pertaining to this case. I don't know whether you have seen it. She had a chest CT which showed bilateral lung nodules of variable size and on the most peripheral and lateral part. So there were debates whether these nodules are metastasis or not. They tried to do transthoracic core needle biopsy, but it was not revealing. So the debate was that could this be probably metastatic? As you all know, the sarcomas tends to metastasize to the lung, the hematogenous route. But still the confirmation is not made by the histologic evaluation. So the metastatic status for the clinician, it looks metastasis, but from pathological point of view, because there is no histological confirmation, we are not able to confirm or rule in or rule out the metastasis.
Yeah, that's a great question. And I think it depends a fair bit on the demographics and the risk profile of your patient. Obviously, if you see vascular invasion in your tumor, and so forth, then of course that would put a little bit of additional weight on those likely being metastatic disease. But if you're not able to sample them and confirm that in a setting where patients may have had, this is an adult patient who's had a long life and so forth, there are a lot of other things that can cause pulmonary nodules and so forth, old granulomatous disease, various allergic phenomena, and so forth and so on. So you don't want to, I don't think you want to treat them as metastatic disease unless you've got histologic proof that that is what indeed is going on. And if they're not symptomatic, then in that situation, I would think if you've tried and you've been unsuccessful, that then what you may wish to do before you would treat them would be to um, let a period of time elapse and follow up radiographically to see if you can detect growth or expansion. Because if they're stable, they're probably not metastatic disease. They may have been there for years, but if over the course of 3, 6, 9 months or whatever, they're increasing in size, then that's certainly a pretty good suspicion that they're going to be malignant. Do we have time for your second case? Or actually, we have a few minutes. Do you want to try to do your second case, or should we have Najat share one of her cases?
If she can open and project it, it's very short and interesting case.
Okay.
Is it possible to open it? Probably
From what I
she
can
can't
see on the Echo website, what's
case one.
right there I can't open.
So maybe we can work on that offline, and maybe Najat, do you want to bring up your case?
Shall I share my screen or shall
Yes,
say
please,
it?
please share your screen. Yeah.
In the meantime, while Najat's sharing, sorry. Okay. No, it's
It's
okay.
okay. Uh, this was a case. We received a punch biopsy specimen from a vaginal mass. She was a 20 years old virgin, and she has been having this persistent vaginal bleeding for the past 3 years, 4 years, I think, since the age of 16.
Hey,
And
Najat.
The file didn't
yes,
open for us to see.
okay. Can you see it now?
No, we just see your folder with the list of the images.
Okay, let me share it again. Can you share now? Can you see it now?
Yes, yes.
Yeah.
Okay.
So this is a
So
vaginal mass in a young 24-year-old woman.
yeah, they say it's a cervical mass with extension to the upper 1/3 of the vagina. Because she was a virgin, they took the sample from the vaginal area, but the mass involves also the cervix.
Okay.
And on the imaging, the bulk of the mass is on the cervical area.
Okay.
And this is the mass. We saw the case with Dr. Ondosan. We thought there are some mucin area, and the nuclei of the cells are relatively blunt. In the architecture, there is solid architecture. There are tubulocystic areas, and as you can see, there is not much atypia. There are scattered mitosis, not to say there are not much, and there is scattered relatively larger cell. The polymorphism was not that much. And we thought of mucinous adenocarcinoma, and also probably clear cell adenocarcinoma. We have a lot of going on, and also neuroendocrine. At that time, what was available, the immunohistochemistry that was available was the ER. Can you see?
Yes, the ER looks negative. Yeah.
Yes, and also the other immunohistochemistry, we thought of neuroendocrine possibility, so we do synaptophysin, but it was negative. And considering the age, the ER is negative, and We thought of mesonephric adenocarcinoma or clear cell adenocarcinoma, but we are really confused about the possible diagnosis.
Yeah, so this is a very peculiar situation. Uh, she's young and so forth. I think you still should exclude an HPV-related lesion, but again, she's rather young for an HPV-related adenocarcinoma. Um, but and the other tumors that can produce mucin would include the gastric carcinomas, or gastric type carcinomas, and those, of course, would be HPV negative and mucin positive. And they usually have very abundant mucin, but the mucin here is mostly extracellular. It's not particularly intracellular, which I think is something that we would tend to favor in the gastric type. But that would be certainly a consideration. I don't think this is a benign neoplasm. Um, because I think, as you've indicated, you have confluent cellular growth. It's disorganized. You have a degree of atypia and some mitotic activity. Could this be a uh, salivary type or some unusual type of tumor of that sort? I think that's a remote possibility. But in an atypical presentation like this, that you certainly have to start thinking outside of the box of possibilities. Um, so that's kind of where my brain goes in terms of what to do with this. Um, if we wanted to think about enteric type or gastric type of adenocarcinoma, sometimes the MUC2 or MUC5AC can be useful in confirming that phenotype, but that would go along with the negative staining. For mesonephric type tumors, again, this is an odd pattern for mesonephric type adenocarcinoma. Those usually have a little bit more either microglandular or small glandular appearance, or sometimes a vaguely papillary type of appearance. But doing a PAX8 stain might help in that regard, because they would usually be PAX8 positive and ER negative, as you've shown. So that can be helpful. The other markers for mesonephric type tumors sometimes can include GATA3, which is also often positive in the mesonephric-like or mesonephric type carcinomas. In terms of localization, in the cervix at least, those tumors tend to be a little bit more lateral than sort of central. And so if it seemed to have some degree of laterality, one side or the other, that might be, again, a small factor in favor of a mesonephric-derived tumor. Clear cell carcinomas from the cervix are generally thought to be, they're not recognized any longer. And that is in the setting of patients who have not been exposed to diethylstilbestrol, which was a problem in the United States and some other countries in the middle part of the last century. And their offspring, when they took DES as a anti sort of as a means of preventing abortion, those patients ended up with clear cell carcinoma at a young age. But in the absence of that exposure in utero, I think clear cell carcinoma has essentially disappeared. Now, having said that, sometimes clear cell carcinoma does come or arise from the lower uterine segment and appear to involve the cervix as an endometrial type tumor, but that's usually in much older patients. So in a young patient in this age group, without the DES exposure, if this were a clear cell carcinoma, that would definitely be a reportable case and certainly something you'd want to investigate in terms of exposures, both for the individual and for her mother, because that's very unusual. So to rule out clear cell carcinoma, I think you'd want to think about doing a napsin A stain, which typically will be positive in clear cell carcinomas. Maybe also doing a P53 stain in this setting as well. Clear cell carcinomas usually would be positive with PAX8. And so if that's positive, then you would be looking at the possibility of a clear cell along with the mesonephric tumors. So I think your discussion and your differential here, Najat, is quite good in terms of the considerations. To go much further in terms of classification without additional immunohistochemistries, I think would be difficult. Where are the therapeutic differences going to be? Well, if she has a mesonephric or clear cell carcinoma, those tumors are going to be a little bit less chemosensitive, and her prognosis is probably not going to be good. One other thought that we might consider here is, could this be a extragonadal germ cell tumor? I mean, certainly some of the features here you might think about a yolk sac tumor or something of that sort. So it may be worth seeing if she has an elevated alpha fetoprotein or if this tumor has any other features of a germ cell tumor. That would be, again, very unusual, but, clear cell carcinomas and yolk sac tumor have a lot of morphologic overlap. And so they don't have very much of an age group overlap in the usual situation. So because she's on the younger age, I think thinking about a germ cell tumor, specifically a yolk sac tumor, would be worth doing. I think this would be a great case if you can get some follow-up, maybe with any additional testing or workup, and see and bring it back to us, because I think there's still a lot of learning value in this case as we have looked at it. Do you have a plan, or do you know what the patient's follow-up is going to be?
She was because our diagnostic, my diagnostic consideration was a mesonephric, and for that immunohistochemistry, so we don't have the immunohistochemistry, so she was searching for that immunohistochemistry test, but this week I haven't followed her. I will follow up, and I will bring the case for our next meeting.
Yes, that would be wonderful.
Yeah.
Well, I think we've exhausted the hour, and I appreciate everyone's attendance and participation. I apologize that we didn't have more of our mentors on the line. They would have been perhaps much more helpful than I have been on these topics, but I appreciate the challenge and enjoy interacting with you. And thank you very much for bringing and sharing your cases. Again, I encourage you to work on the self-study materials, and to feel free to email or query us through other means about any of the problems you encounter, either with those materials or with your day-to-day cases. I mean, we want to be active mentors and not just people who show up once a month. We want to really help you progress in your careers and in your diagnostic abilities to help care for the patients in your area. So until next time, we will look forward to seeing you, but if we interact in between now and then, we're happy to do so. Thanks, everyone.
Thank you very much.
Thank you, Prof.
Thank you.
very much.
Everyone. Thanks, Prof. Bye.